Hello and welcome. Let's talk about drugs used in peptic ulcer disease. So, the drugs used includes classification like neutralization of the secreted acid, which includes non-systemic like aluminum hydroxide, magnesium oxide, magnesium and aluminum tricyclate, and the systemic includes sodium bicarbonate and calcium carbonate. The reduction of the gastric acid secretion includes H2 receptor antagonists like cimetidine, ranitidine, famotidine, and nizatidine, and PPIs like omeprazole, lansoprazole, omeprazole, anticholinergic drugs like pyrazine, dicyclomine, and mucosal protective agents like sucralfate, prostaglandin analog, and colloid bismuth compounds. Now, sucralfate. It is a salt of the sucrose complexes to sulfated aluminum hydroxide. It is poorly absorbed from GIT. Mechanism of action. In acidic environments, sucralfate breaks down into sucrose sulfate and an aluminum salt. The sucrose sulfate binds to positively charged proteins in the base of the ulcer or erosions. It forms a viscous, tenacious paste which acts as a physical barrier that prevents further damage. It also stimulates prostaglandin and bicarbonate secretion. Clinical uses for healing of the duodenal ulcer, for decreasing upper gastrointestinal bleeding in ill patients, for prevention of the stress-related bleedings. Now, adverse effects. It is virtually devoid of the systemic adverse effects, and constipation may occur due to aluminum. Drug interaction. It may bind to the other drugs and impede their absorption. Now, antacid. Antacids are the weak bases out of which hydroxide is common. It neutralizes already formed acid, and there is no single ideal antacid. It is usually given after meal. Mechanism of action. Antacids react with the gastric hydrochloric acid and neutralizes gastric acid by forming salt and water. As a result, there is decrease in the gastric acidity. It may also promote mucosal defense mechanism by stimulating mucosal prostaglandin production. It also decreases pepsin activity because pepsin inactivates in the solutions above pH 4. Now, clinical uses. To promote the healing of the ulcer, for relief of the pain from esophagitis, gastric and duodenal ulcer, so used in dyspepsia and acid peptic disorders. Adverse effects: belching, distension, metabolic alkalosis, milk alkali syndrome, fluid retention in the patients with heart failure, hypertension, hypercalcemia, renal insufficiency, nephrolithiasis, rebound acidity may be seen. Diarrhea, constipation, and drug interaction leading to decreased absorption of drugs like tetracycline, fluoroquinolones, iron, and ketoconazole are seen. Now, the choice of the antacid or ideal antacid. There is no single antacid is satisfactory, and combination is frequently used. And the best ideal combination is magnesium and aluminum hydroxide. The advantage of the combination is that these react slowly with hydrochloric acid to form magnesium chloride, aluminum chloride, and water. Then no gas generated, so there is no belching, and the metabolic alkalosis is uncommon. It causes osmotic diarrhea, and aluminum hydroxide causes constipation, so both can minimize the impact upon bowel function. So the time at which antacid should be given is usually after meal because it neutralizes the already formed HCl. Now, milk alkali syndrome. Excessive doses of either sodium bicarbonate or calcium carbonate with calcium containing dairy products can lead to hypercalcemia and metabolic alkalosis, which is known as milk alkali syndrome. The signs and symptoms include headache, anorexia, vomiting, abdominal pain, and constipation. The solution is that non-systemic buffered antacids are better. Now, H2 receptor blockers. These are the selective H2 receptor blockers, and the use is declined because of the presence or availability of proton pump inhibitors. These are OTC drugs and usually well tolerated. These include drugs like cimetidine, ranitidine, famotidine, and nizatidine. Pharmacokinetics. The first-pass metabolism leads to bioavailability about 50%. The serum half-life is 1 to 1.4 hours, and the duration of the action depends on the dose. Mechanism of action. H2 blockers competitively and reversibly bind with H2 receptor present on the gastric parietal cell membrane and inhibits H2 receptors, leading to CAMP of parietal cell, leading to decreased gastric acid secretion. Clinical uses. It is taken before meal, and gastroesophageal reflux disease are the common indication, peptic ulcer disease, non-ulcer dyspepsia, and prevention of the bleeding from stress-related gastritis. Now, this is a picture showing the mechanism of action of different kind of drugs. These include sucralfate, proton pump inhibitors, antacids, H2 antagonists, and others. This is another picture showing mechanism of action on the parietal cell of different drugs. This is another picture showing the molecular level mechanism of action of cimetidine, misoprostol, omeprazole, and dicyclomine. This is another picture showing the mechanism of action on cellular membrane level. Now, adverse effects: diarrhea, headache, fatigue, myalgia, constipation, confusion, hallucination, agitation, galactorrhea due to cimetidine may be seen. It increases prolactin level. It crosses the placenta, so not given in the pregnancy and lactating mother. Blood dyscrasia, bradycardia, hypotension, and reversible abnormal liver function may be seen. Now, proton pump inhibitors. These are the most widely used drug. These are the prodrugs and highly efficacious. These are safe, superior to H2 blocker, and single dose inhibits 90 to 98% of the HCl secretion. It is an ideal drug because of the short half-life, long duration of action, and concentrated and activated near the site of action. These include drugs like omeprazole, pantoprazole, lansoprazole, and esomeprazole. Now, pharmacokinetics. These can be given orally. These are all product, and there is a rapid fast pass and systemic hepatic metabolism. Now, mechanism of action. It is a product which is absorbed from the intestine and rapidly enters into the parietal cell canaliculi and become protonated and concentrated in the parietal cell about more than 1000-fold and converted to the active reactive theophyllic sulfonamide cation and reacts with hydrogen potassium ATPase and forms covalent disulfide linkage, and there is irreversible inactivation leading to by hydrogen potassium ATPase enzymes, thereby blocks the final common pathway of the acid secretion. Now, clinical uses for GERD, peptic ulcer disease like duodenal ulcer, gastric ulcer, H. pylori associated ulcer in the form of triple therapy, NSAID associated ulcer, and prevention of the rebleeding from peptic ulcer, non-ulcer dyspepsia, and prevention of the stress-related mucosal bleeding and gastrinoma. So, how PPIs promote eradication of the H. pylori infection? These increase intragastric pH, thereby reduce the MICF antimicrobial against H. pylori, and there is minor direct antimicrobial properties. Now, eradication of H. pylori or triple therapy. The aim is to heal the ulcer and eradicate the organism. Now, the 7 days regimen includes omeprazole 40 mg per day or lansoprazole 30 mg, clarithromycin 500 mg, and metronidazole 400 mg. The 14 days regimen includes omeprazole 40 mg per day or lansoprazole 30 mg, amoxicillin 1000 mg, and clarithromycin 500 mg. And after completion of the triple therapy, the proton pump inhibitors should be continued once daily for 4 to 6 weeks to ensure complete ulcer healing. So, why PPI and antimicrobial agents are given together? The proton pump inhibitors increase the intergastric pH and decreases the microbial contents of the antibiotics against Helicobacter pylori. Adverse effect: diarrhea, headache, abdominal pain, reduced vitamin B12 absorption, reduced absorption of the food-bound mineral like iron, calcium, zinc, and there is an increased risk of enteric infections, increased risk of community-acquired respiratory infections may be seen. In case of the there is increased gastrin level, and increased proliferation of the colonic mucosa leading to hypergastrinoma. Long-term use may reduce HCl and favors colonization of the bacteria in the stomach and converts ingested nitrates to nitrosamine, which can cause gastric polyp, and carcinogens may be seen. Now, colloidal bismuth compounds. These are the OTC mucosal protective agents, includes bismuth subsalicylate, bismuth subcitrate, and bismuth dinitrate. It is there is rapid dissociation within the stomach, and there is increased or more than 99% appearance in the stool, and there is slow renal excretion. The mechanism of action includes selectively chelation with protein material in the ulcer base and forms coating and creates a protective against acid and pepsin. It may stimulate prostaglandins, mucus, and bicarbonate secretion, and direct antimicrobial activity against H. pylori may be seen. Clinical uses for non-specific dyspepsia, acute diarrhea leading to reduced frequency and liquidity of stool due to inhibition of the prostaglandin and chloride secretion by salicylate. The prevention of the traveler's diarrhea. In case of the triple therapy, it is a second-line therapy where bismuth salicylate 2-tab is used with tetracycline 500 and metronidazole 250 mg 4 times daily for 14 days. Adverse effects include blackening of the stool, harmless darkening of the tongue, encephalopathy, and salicylate toxicity may be seen in high dose. End of the topic.